Take a look today into the aspect of technique. Technique deals with that part of psychoanalysis which has to do with how to do therapy, the operational part of psychoanalysis. Technique is different for different schools of psychoanalysis. Technique can also differ based upon the client group you are dealing with, be it a child, adult, or a person in old age. Technique can also differ from school to school. Jungian technique would be radically different than Freudian technique. ISTDP technique would be radically different than cohesion technique. We will discuss today what this word technique means. As we discuss it over a few sessions, this word will acquire its meaning and we will go deeper and wider into the area of technique, taking up one by one conceptual themes, operational issues related to doing therapy. In this series of technique, we will essentially engage with how to do therapy in operational terms, which is to say, once the theory part is clear, you are clear about the theory part. Once the theory part is clear and you want to do therapy now, how will you do therapy in operational terms? And this area is what is called as technique. The study of doing it, the operational part of psychoanalysis. If you want to divide psychoanalysis as a edifice, one way to divide it is to divide it into 5 parts. The philosophy of psychoanalysis, and each school of psychoanalysis would have its own philosophy. Many of them would share a philosophy. For example, the Freudian school, the Kleinian school, the Bayonian school would share a philosophy, whereas Jungian school would have a different philosophy. So one aspect of psychoanalysis is the philosophy. Do you believe in materialism? Do you believe in the concept of soul? Do you believe in the existential philosophy of there being no purpose and we are just thrown into this world? Or do you believe in design behind the human mind and existence? So these are areas of philosophy. Second are the concepts. Concepts related to model of the mind, concepts related to developmental phases, concepts related to those phenomena which lead to pathology, concepts related to how variables are working, how defenses are working in the mind. Then we have pathogenesis. Using the concepts, we go into how any particular pathology develops. For example, how paranoia develops, how addiction develops, how depression develops, how bipolarity develops. What is the pathogenesis of these things in early childhood? And this, of course, we do using the concepts. Technique then comes, once we are clear about pathogenesis, we are clear about how it has happened, then we get an idea about how to heal it. How to heal it is always a function of how it has happened. So technique will always be a function of pathogenesis, and pathogenesis always will be in terms of the concepts, and the concepts will be in terms of the philosophy. There is an alignment through the 5 of them. And then we have, so technique deals with how to do healing, how to do therapy. When the patient comes to you for a fixed amount of time, be it 45 minutes, 1 hour or 3 hours, what to do in that time, how to do therapy. That is dealt with by technique. So technique is the most practical and the operational part, the clinical part of action. And then we have psychometrics, how to measure things. And this can be used at the level of pathogenesis to find out after case history what is the intensity of something. And there are various psychoanalytic tools in psychometrics. So psychometrics is the science of measurement in psychology, and you can measure anything that you want. In clinical psychology, we are trying to measure what has caused problems, or if there is a problem related to, say, anger, what is the level of the problem, or related to fear or anxiety, what is the level of anxiety. In more complicated, deeper, profound instances, we can use something like CAT, TAT or OSHO to find out what is in the unconscious mind. And this will be more in qualitative subjective terms rather than in quantitative objective terms. Psychometric tools which are psychoanalytically oriented, because you can have psychometric tools which are not psychoanalytically oriented, but if we focus on those psychometric tools which are psychoanalytically oriented, like thematic apperception test, child apperception test, sentence completion test, all projection tests, ROSHA, all these are psychoanalytic psychometric tools, and they can be used after giving the case, after taking the case history, to find out if we have some doubt, or to confirm if we believe in something, or to make more exact and quantitative assessment of something. And this can also be used during therapy at regular intervals to find out how is the improvement happening or not happening. It can also be used as a confirmatory assisting tool, not confirmatory but assisting tool in termination of therapy. So these 5 are broad areas of psychoanalysis. This, if you look at this 5, we can divide all schools of psychoanalysis based on how profound they are on these 5 parameters. And that allows us to divide all schools of psychoanalysis into 3 categories. Full schools, quarter schools, and half schools. This is my classification. I divide all schools in psychoanalysis into 3 categories. Full schools, quarter schools, full schools, 3/4 schools, and half schools. Full school is the one which has its own philosophy clearly articulated, its own model of the mind, its own pathology, pathogenesis, and healing technique. So if you have philosophy, model of the mind, pathogenesis, healing technique, all in alignment, I would call that school a full school. Unfortunately, there is no full school in psychoanalysis. The next category is 3/4 schools, where you have a model of the mind. You don't have philosophy, but you have a model of the mind, pathogenesis based upon the model of the mind, and healing technique based upon pathogenesis. So there is a clear alignment of a clearly articulated model of the mind leading to a particular kind of pathogenesis of any problem, leading to a healing technique. I would call the Freudian school and the Jungian school as 3/4 schools. And then you have half schools. half schools don't have this alignment of model of the mind, pathogenesis and healing technique. The model of the mind goes away. So now you are left with certain concepts and phenomena which are used to articulate a pathogenesis, and then based upon pathogenesis a healing technique. The Kleinian school, Bjornian school, Winnicottian school, Cohusian school, ISTDP, they are all half schools. What is missing there is they neither have philosophy nor they have a model of the mind. So this is the whole arcade of psychoanalysis. Now in this arcade, which is a 5-pillar arcade, one pillar is of technique, which deals with how to do therapy, what to do when the patient is with you in the therapy room, the operational part, the clinical part, the healing part, the action part of psychoanalysis. So let us go into this study of this part called the technique. Technique, as we saw above, is one of the pillars of the whole arcade of psychoanalysis, one of the 5 pillars. If we take up this pillar and go in details, we see this pillar itself is constituted of, or rather not constituted of, but it can be studied by studying 5 aspects that are integral to it. First is the aspect of the frame, the psychoanalytic frame. Frame refers to the framework within which therapy happens. So the framework is the patient will come to the clinic, the therapy center, at the same place, at the pre-decided time for a fixed period of the session, which can be 45 minutes, 1 hour or longer, whatever is decided between the two. The patient comes for therapy on a regular basis and the therapy happens in a particular way. The therapist sits in a particular way, either in front of the patient or behind the patient. And the patient is free to say whatever comes to his mind. The therapist gives interpretations or interventions or allows something to just pass. And the patient pays money as decided between the two for the services he is receiving. And this interaction is strictly for the purpose of healing. It is not to create personal relationships, and it is strictly related to the therapy room. It does not go outside. This constitutes the broad frame of technique, the core framework within which action will happen. So the framework is what is called the frame. It relates to the space, it relates to time, it relates to money, it relates to certain basic do's and don'ts of how things will go forward between the client and the therapist. This is the frame. So these are do's and don'ts of things which are going to happen in the therapy room. The broad do's and don'ts which will contain the action in the therapy room. This is the psychoanalytic frame. Second, we'll look in details as we go into the next slide. Second important element is actually doing it. When the patient starts talking to you, how do you bring in your knowledge and how do you respond to the patient? What do you do in that interaction? The core of therapy, doing it. And this involves technique concepts like transference, projective identification, and many others which we'll see in this series on technique. That once the action starts, how do you do? Third part is, and here comes the technique, the concepts of technique. Concepts related to transference, counter transference, projective identification, delayed projective identification, the use of silence, and a whole list of concepts. We'll see them as we go ahead. Third is general do's and don'ts of therapy. For example, if the patient does not come on time, should you call him up? If he does not pay on time, should you call him up? If he comes late, should you bring it to his notice? what to do and what not to do on 100 small things which are everyday things and keep happening in therapy very often, very pervasively. Very importantly is how to do. Not only do's and don'ts, but when it comes to the do's, how to do the do's. And when it comes to don'ts, how to do the don'ts or how not to do the don'ts. So do's and don'ts and the how related to do's and don'ts. This is very important. So there is a general discussion on do's and don'ts and the how related to do's and don'ts for therapy. And then there are exceptional situations for which one may have to take a break from the general guidelines and accommodate the exceptionality of the situation by crossing the line and doing something that generally one won't do. And last is termination. When do we believe the healing is done? Or even if the healing is not done, it is time for termination. That substantially the goals of therapy are achieved. And this would of course bring us into the idea of, into the discussion of what is the goal of therapy. And on all these points, the frame, the doing, the do's and don'ts, exceptional situation, termination, on all these points, every school of psychoanalysis would have certain common agreements with every other school and certain unique things to itself. So there is no one answer in psychoanalysis to frame, to doing, to do's and don'ts. There always will be differences between different schools of psychoanalysis. So we'll have to look into each of the concepts of technique school by school. These answers to these questions, these issues can also differ in terms of categories of patients we are dealing with. One category of patient may require us to very strictly follow the frame. And another category of patients may require us to loosen up the frame and not be very strict about the frame. One category of patients may force us or rather lead us to working in transference. Another category of patients, we can't work in transference, it's not so productive. So every issue in technique has multiple answers. There is no one answer for any issue in technique. And the answers differ from based on the schools of psychoanalysis, based on the age of patients we are dealing with, and based upon the pathology we are dealing with. Occasionally, it also depends upon the exceptionality of the patient himself, if the patient is exceptionally fragile or exceptionally tough. So let us go further into it. So technique is not one. Each school of psychoanalysis has its own form of technique. The Freudian technique is very different from the Jungian technique, is very different from the Kleinian technique, and so on. Let us take a few examples. In Freudian technique, Freud himself insisted on having sessions 5 days a week, and each session was of 50 minutes. 50 minutes because Freud could not avoid his desire to smoke, and he required 10 minutes to smoke before the next patient came in. So this became a convention. Most people now follow a 45-minute rule. Some people follow a 1-hour session. And Freud insisted it has to be 5 days a week. And anything less than 3 days is not psychoanalysis at all. And Freud insisted all the sessions have to be on the couch. The patient has to be on the couch and the analyst has to be, the therapist has to be behind the patient, sitting on a chair, but in a way the patient cannot see him. He has to be out of sight of the patient. So the patient is on the couch looking in the front and the analyst is behind him, out of line of sight. Jung used a very different technique. He used to do it face to face. He would sit on a chair and the client would sit on a chair, and he would manage, or rather he would prefer, not more than 2 days a week. And in extreme cases, he would go to 3, but most common he would have once a week or twice a week, which was very different from the Freudian method. If you look at the Kleinian method, they predominantly work in transference, far more than the Freudians practically do. And needless to say, the interpretations which they make are all based upon the school from where they come. So if the client is saying X, the interpretation which is given by a Freudian is based upon Freud's concepts of the Oedipus, of the anal fixations and so on. Whereas a Jungian gives interpretations based upon the Jungian concepts of the collective unconscious, archetypes, program of life, individuation and so on. And the Kleinian gives interpretations based upon the good and the bad breast, part-object relationships, the split being open, the depressive position, envy, gratitude, greed, guilt, and so on. So, how therapy happens differs from school to school, not only in terms of interpretations given, which are completely based upon the theory of the school where one comes from. That of course is a central difference, but there are other technique differences also in terms of how many sessions per week. Should the session be on the couch or should it be face to face? What should be the length of the session and so on. So the technique differs from school to school. Technique also differs based upon other parameters. For example, let us say somebody is practicing Freudian technique. He won't be able to do the same kind of technique in its micro details when it comes to dealing with a patient of psychosis and a patient of addiction. The spelling is wrong, it's addiction, it's not additions. And the same Freudian, if he is dealing with children, adult men, women and people in old age, would have to customize his technique for each of them. The same Freudian would have to customize his technique for a fragile patient and an absolutely high ego strength patient. So technique differs based upon the type of problem, the type of personality, the age of the person, the psychological, the mental and intellectual capacity of the person, the ego strength of the person. So there is nothing called one technique in psychoanalysis. What we call technique has certain common elements across all schools of psychoanalysis, and then there are variations from school to school, and within each school there are variations based upon type of pathology, age of the person, ego strength of the person, and of course person to person variations of technique also come in. Let us look at the first point of technique, the frame. So when we look at the psychoanalytic frame, when we look at the psychoanalytic frame, let us go into elements of this frame, slight more details than we referred to in a concise way. Why do we have to create this frame? It looks to be a very artificial setup in one way, a productive setup, purposeful setup, very creative setup, yet an artificial setup. So where was the need to create this setup? We have to go back to Freud, who laid the foundation of psychoanalysis, including technique. Freud said all human relationships essentially are variations and combinations of three fundamental relationships: the relationship of parent-child, the relationship of teacher-student, and the relationship of siblings. And all other relationships are variations or combinations of these fundamental templates. And Freud said these three relationships and their templates, as we see in society, are not adequate for healing purposes. And obviously we see that anyone who has psychological issue first tries to get it resolved by talking to a parent, a teacher, a sibling, friends, and so on. Does not help out. It does not help out in serious cases, of course. In mild cases it does help, but in moderate and serious cases does not help, and one needs professional help. But why does it not work out? It does not work out for a variety of reasons. Knowledge and skill of therapy being one, but one of the reasons it does not work out is because of the absence of the frame. That the traditional frameworks of relating are not adequate for the purpose of healing. And therefore Freud felt a fourth kind of relationship was necessary. And this had to be created. It is not something that organically, naturally emerges. And therefore Freud created the fourth kind of relationship, the therapist-patient relationship, and this demanded that this should happen within a frame, so that this relationship, which is a unique kind of relationship, is fortified and sustained. And so the psychoanalytic frame is the frame which helps us to support the healing process. And the frame is created, this artificial situation of therapy is created so that healing is supported. And we require artificial setup because the natural setups are not adequately productive for healing. Therefore, need compels us to create the psychoanalytic frame. And a unique fourth kind of relationship which is unequal between the therapist and the patient. So let us now, once we are clear about the necessity of the frame and how Freud created it, let us go into the elements of frame. So within psychoanalysis we have technique. Within technique we have many areas. One of the areas is frame, and within frame we have these elementals. Let us look at these elements that fall under the arcade of frame. First is space. There should be a fixed space where therapy happens. The space should not change. There has to be a constancy of space. Wherever it is, the therapist and the patient should meet in the same place for the entire process of therapy, even if it goes on for 2 years, 3 years, 7 years, whatever be the duration. Change of space should be avoided to the extent possible. It provides a sense of stability, reliability, constancy to the patient. It provides a sense of familiarity, trust, and safety to the patient. And over a period of time, the patient relates to that space, and that quietness, the stability, the peace of the space is internalized by the patient. The space, therefore, is very important, and so far as possible, the space should not be changed. If you change the space, You can immediately see the response of the patient in the session. There are responses of being unsettled, angry, irritated. And at times, the very change of space consumes much of the session, discussing how difficult this place is or how better this place is than the other place. And unnecessarily a new element is added and sessions get consumed up. We are supposed to discuss issues which have been undiscussed and are lying inside the patient. We are not supposed to create new issues on which to discuss and pass time in therapy. So space is very important. Space should be comfortable, not only constant but comfortable. Space should not be in an area where the patient finds it difficult to reach or is afraid to go. The space should be such that it allows anonymity to the patient, confidentiality to the patient. It should not be a space where the patient walks in and the whole world looks at him. Or the patient walks out and three other people who are waiting in the waiting room, they look at him. So space should be such that confidentiality should be maintained. There are two aspects of confidentiality, audio and video. At times, in certain hospital settings, it is not possible to maintain visual confidentiality, but audio confidentiality is a strict yes. If audio confidentiality cannot be maintained, it's difficult to do psychoanalysis. So space should be such that confidentiality is maintained. In today's time, as we do therapy online, this becomes even more important, that nobody is in the room of the therapist or nobody is in the room of the patient. Not only they should not be on camera, they should not be in the room, they should not be outside of the room listening to what is happening. So audio confidentiality and visual confidentiality are necessary. Even if visual is compromised, it's not good if it's compromised, but even if it is, there is no question of audio compromise or confidentiality. Otherwise, it's very difficult to do psychoanalysis. Time should be fixed. Second important element of the frame is the time. Time should not vary week by week. It should be the same time, same day. It is preferred that the same time exists for all the days of the week. For example, if somebody is coming Monday, Thursday and Saturday at 4 to 5, it is preferable he comes 4 to 5 on all the 3 days. If not, let us say he comes Monday 4 to 5, Tuesday 7 to 8 and Saturday 4 to 5 or Saturday 2 to 3. Then at least on these days, the time should be the same. It should not change week by week. Constancy of the same time is very necessary. This also provides stability, reliability, structure and consistency so necessary for the patient to experience and internalize. Because most patients come from backgrounds where the parents were not good, reliable, stable objects. Parents were unpredictable, inconsistent, unreasonable, difficult to make out, difficult to predict. And there is too much of flux and anxiety and unpredictability and sudden attacks in life. So the constancy of time is very necessary. We have to start at the right time and end at the right time. Often people bring out the best of the material towards the end of the session and one feels tempted to extend the session by a few minutes so that the interesting material can be dealt with. And on this point, there are two different opinions. Some people strictly enforce the frame and they believe if something is really important, it will come up again. And some don't take a chance. They extend it by 5 minutes and deal with the material, pointing it out to the person that how he's bringing up the material towards the end, and that may have many motivations, including leaving it half processed, not seeing it through to closure, or leaving it for the therapist to process and come back. It may be avoidance of affect related to what one wants to be processed, but is afraid of the affect related to it. If the time of the session is not adequate, we should go for more sessions, but once decided, whatever is the duration of the session, that has to be maintained as sacrosanct. Money is another important element of frame. The therapist has to decide his fees, and usually they do based upon the seniority of the person, the skills, the type of work he does, and many other factors. Whatever money is decided, it has to be adequate, that in the middle of therapy, after a few sessions or after 6 months or 8 months, the therapist does not lose interest, does not get frustrated, does not get angry with the patient because he's paying too less. At the same time, the patient should not have the same feelings towards the therapist for extracting too much money from him. So money has to be something which is comfortable to both, and it has to be paid on time as decided. It can be per session after the finishing of the sessions. It can be before the session. It can be weekly basis. It can be monthly basis. Whatever is the mode of payment decided, whatever is the per session charge decided, it has to be followed through. And if there is any increase in the fees, it has to be on an announced basis. So therapists announce before the starting of therapy that every year I increase my fees by 10% to cover inflation or the increased cost of living, and every year it will increase by a predictable amount. So this has to be transparently communicated, and it has to be a stable, reliable figure. It should not be a traumatic surprise to the patient. The couch can be used if this is a part of the process, except for Jung and ISTDP. Everyone in psychoanalysis uses the couch. So couch is very much a part of the frame except for these two schools. There is a difference between a couch-based therapy and a face-to-face therapy. If one wants to go into the surreal part of the mind, early life part of the mind, explore the fantasies, deep-seated fantasies, couch is better. If one wants to mobilize one's will and use one's will to bring about a change and use awareness and not go into reverie, one is dealing more with reason and catharsis in a very conscious way, then face-to-face is better. Number of sessions per week also is a very important element. So length of the session and number of sessions per week. Classical Freudian, it has to be 3 to 5. Freudian, Kleinian, Bayonian, 3 to 5. Anything less than 3, they say it's not psychoanalysis at all. In ISTDP and in Jungian approach, things are different. In the Jungian approach, the length is not different, but usually they have less sessions, 2 sessions per week. And I find it very reasonable. I use 2 sessions per week. One of the reasons is most of my clients are from personality disorders. I don't have clients from the psychotic spectrum, but when I have them, then it would need 3 or 4 sessions per week. But for the spectrum of neurosis, for the spectrum of personality disorder, addiction, mood disorder, for the spectrum of mild circumscribed psychosis, 2 sessions per week can be enough. If the time is not adequate, one can increase the length of the session from 1 hour to 1.5 hours, if need be 2 hours. But it's very difficult to call clients in today's times 3 or 4 times a week. The time spent in travel, in such traffic, and the time not available free from the job are realities of our age. So it's very difficult to call anybody more than twice a week. So what I do is I increase the length of the session to 1.5 hours usually, and occasionally, very rarely, 2 hours. But I prefer to keep it maximum twice a week. But in certain cases of psychosis or extreme fragility, one may have to go for 3 or 4 sessions a week. There is this idea of a blank screen, the anonymity of the therapist. One of the important elements of the frame is that the therapist should not do self-revelation. The client should not know anything personal about the therapist, and the therapist should appear completely anonymous like a white blank screen. He should not give himself away in the communication. This is a very important element, the anonymity of the therapist. Why is it so important? It is important because the discussion has to be for therapy of the client, and it should not go in discussion of the therapist or the life of the therapist. The client is paying for his own healing. He is not paying for the therapy of the therapist. So the discussion has to be about the client and not about the therapist. Second, client should not get into a situation where he uses something real about the therapist as a defense or as a refusal to change for good. Third, the core issue of transference, that when the person appears as a blank screen and the client says you are greedy, the client does not know anything about the person in reality, but he very strongly feels the person is greedy, and that is a transference of he feels greedy about that his parents are greedy or his boss is greedy or somebody close to him is greedy, and he puts it onto the therapist, and this then becomes an occasion for healing, that the therapist can point out or ask for what evidence in reality makes him say what he is saying. And when the person cannot find out any reason, he realizes that this strong belief about the therapist is actually a transfer, a displacement from someone else, and that someone else is the one about whom he feels that person is greedy, but he is not able to accept it to himself. So the less person knows in reality about the client, more easy it is for the therapist to say it is a transference. If, let us say, in reality the therapist is greedy and the patient knows about it and he says you are greedy, then it is not a transference, it's just a statement of reality. And then there would be confusion about what the patient is saying. Is it a statement in reality or is it a transference? So to identify transference as transference, it is necessary to keep the therapist anonymous. Now, how anonymous can a therapist be? Because when the client goes to the office of the therapist, depending on which office complex the center is or how the interior decor is, it gives away the economic details about the therapist. When the person sees the therapist, there is no way the therapist can hide many parts of himself. They are going to be communicated implicitly. The person may have written books, the therapist may have written books, created videos on YouTube, may have a social media profile, and all of that is self-revelation. The client may go on social media and find out these details. How much anonymity you want depends on how pure a transference you want and what you are going to do with that transference. We'll come to that point later, but what we discuss at present is this: absolute anonymity is not possible, but we can go for a relative anonymity, that there should be a reasonable anonymity, a reasonable enough anonymity of the therapist, so that the transference is not disturbed. The frame also brings in the power differential. If the client asks the therapist something personal, the therapist can just refuse to say, I won't like to share it, or this is therapy is about you, not about me. Can we focus upon you? The client can't say this to the therapist. The client essentially is supposed to reveal ideas that come to him, feelings that come to him during the session. And therefore, there is a power differential. For example, if at a pre-appointed time the client does not come up, he misses the session. Many therapists have a cancellation policy where they say, if it is not cancelled 48 hours in advance and the client does not come, the client has to pay. But if the therapist has an emergency and the therapist does not come and reschedules at the last moment, he doesn't pay to the client, or he doesn't let go of payment for one session, or he does not compensate by doing another free session. So there is a power differential. The frame also involves the space, and the space has one element of the interior decor. The paint which is used, the way painting is done, what artifacts are kept for interior decor. If there are any paintings used or any objects which are kept, they should be to the minimum. The more objects are kept for interior decor, the more fancy a paint is done, the more it reveals about the therapist. And often it becomes a subject of discussion in a session, anything which is lying around in the room. So it is better to be as Spartan as possible, as austere as possible. So minimalism and beauty in austerity is a good principle for interior decor of a therapy room. In no situation we should use paintings which solicit very negative responses from people of high anxiety or high fear, or high anger. The artifacts in the room, the painting should not be like Rorschach plates which solicit responses which are not needed by the therapist on an everyday basis. The constancy of space and environment is very important. If there are paintings, artifacts, objects in the room, they should be where they are. Any change in their relative location or absolute location is a difficulty. In fragile patients, this is very important. They want constancy. During COVID, I used to do it online, and if I would change the computer, instead of using the desktop, which is more clear, if I use my old laptop where the clarity is not high, just the change in that situation is pointed out by the patient and he feels very uncomfortable. In some hospital settings, the constancy of space and environment even includes use of uniform by the professional staff. They use the same uniform to maintain constancy. More elements of frame. Frame includes the taking in of the patient. Who should you take as a patient? It's very important because this is one of those areas where it's not easy to drop a patient midway. And if it does not go well with the patient, it is difficult for both of them. So it's very necessary to have a clear understanding about what kind of patient one should take and what kind of patient one should not take. And three elements are very necessary here. One, the knowledge and the skill of the therapist. We should not take anybody where a different set of knowledge or skill is required and we don't have the depth of knowledge and skill. We should not take people where the dislike is very high, let me say. On a person-to-person basis, the dislike is very high. Some people take it up as a challenge and they say this should be the patients we should always be taking, and then take it to the supervisor to work out why I don't like this patient. But this is an ambitious position. Many people get into this ambitious position, are not able to pull it off, and then it becomes a horrible thing in the middle of it. So if you are in training and you do it, it's okay. But if you are a practicing person not in training, and despite all years of teaching and supervision, you still dislike certain types of people, it is better to accept it as a fact of life. Capacity of the therapist is very important. Therapy does not need to be a 10 to 5 job. Many therapists can't do more than 2 or 3 sessions a day, and this has to be accepted. If you go beyond your capacity for a long period of time, your own psychological health or your quality of life deteriorates, and then the work starts showing up. The adverse impact on the work starts showing up. So if you do too many sessions without gap in between 2 sessions, there must be a gap of half an hour. You can't run it like a factory 10 to 10. If you run it like a factory 10 to 10, it inevitably shows up in the quality of work. So if you are doing a 1 hour session, better to do only 3 to 4 sessions a day with a gap of half an hour between sessions. I prefer 3 sessions a day with a gap of half an hour to 1 hour in between. If you are doing a ISTDP session of 3 hours, better to have one pre-lunch and one post-lunch. School in which the therapist is trained and the school which is required for the pathology of person, that compatibility is also very important. If the pathology of the person requires knowledge and skill of a school you are not trained in, better to refer the person to somebody who is right for the person. Some psychoanalysts said it very interesting. I think it was Rilke, I'm not sure, Rilke or somebody else, but he said, it is okay if you don't like a patient in the beginning, but something is wrong if you don't like him in the end. And that is true. And there can be a group of people you just can't like, whether in the beginning or in the end, and that has an impact on therapy. So we have to be honest, not be omnipotent, not be unrealistically ambitious and get into dealing of everybody, regardless of if it's our cup of tea or not. We also have to be very clear if we want a 24/7 engagement, because if we take high anxiety patients, very sick patients, psychotic patients, we can have emergency calls at any time, and it can go to an extent where we might be forced to say this requires a hospital setup, a backup, a 24-hour backup. It's not something that an individual can pull off. So we have to be very clear about what type of patients we wish to see. Avoidance of dual relationships. A therapist cannot have any other relationship with the patient other than that of a therapist and a patient. So the therapist should not have any commercial dealings, not take any benefit in cash or kind other than the fee, nor get into any commercial relationship or social relationship with the person, with the patient. In small towns, it might be difficult to avoid dual relationship, especially relationship of a student and the therapist and the teacher, that your patient might be your student also, or your student might turn to be your patient. It's very difficult to avoid these things in smaller towns where you don't have options, especially in the developing countries where therapists in number are very few and good therapists even fewer. Dual relationships should be strictly avoided, like asking the patient to ask somebody he knows do some work for you, or vice versa. So it has to be a very isolated relationship of a patient and the therapist. There should not be any dual interaction, any dual relationship, any dual transaction with the patient outside of the therapy room, commercial or non-commercial. The patient may desire that you should keep doing therapy 24/7. The patient may call you, may try to talk to you, but we have to keep the therapy within the frame of therapy, and we should not be doing therapy outside of the therapy room. So if the patient wants more interaction, ask him to come for more sessions. But don't have informal, unpaid sessions on phone or Zoom, and never meet the patient over a cup of coffee to continue discussing therapy. The therapist should not develop any personal interest and maintain the neutrality of the frame. Beyond says we should work without memory and desire. This is an ideal. But what we mean by personal interest in everyday reasonable terms is this. when the person talks about his interest in relationship with somebody X, we should not be for or against X. We should not develop a personal interest that the patient should do X and not Y. We should discuss it with the patient, but ultimately leave it to the patient. Our discussion, our analysis should never be crossing the line into insistence, no matter how mild it would be. We should not show displeasure where patient does something we don't like. So prevailing upon the patient in various subtle ways can happen. And this prevailing upon the patient, no matter in how subtle, how mild a way it is, that has to be avoided. And this cannot be stressed enough. This is what Dr. Gargulo says, this cannot be stressed enough, that the therapist should not have any personal investment in what the patient decides. And by personal investment, personal interest, we not only mean that the therapist should not be interested in getting into a personal relationship with the patient or get interested in something commercial the patient does, but we should not have any interest in any decision that patient takes beyond the welfare of the patient without transgressing into the domain of insistence or prevailing or influencing, no matter how mild it is. When I say influencing, I should not be using the word influencing. Let me say insistence and prevailing. Those are better words. Influence we cannot avoid because we do influence the person rightly with psychoanalysis. Termination is a very important element, and there are various ideas on when you should terminate therapy. What should be the goal point where we can accept and declare termination of therapy? This may vary from school to school. Some schools will believe cessation of symptoms is good enough for termination. Some will believe reasonable healing of symptoms, even if not 100%, is good enough for termination. Some will believe it's a lifelong process. The patient has to decide when to terminate. There is no end to the exploration of the unconscious. There is no end to self-transformation. So termination will differ from school to school, but being clear about termination and sharing it with the patient upfront that this would be our goals and this is where we would terminate. That is very necessary. In certain cases, if the patient wants to change a therapist or therapist is going out of town to some other place to reside, or the patient is going out of town, then even before termination, there is a question of handing over the patient to some other therapist. So we have to terminate on our part and hand over the patient to some other therapist, and this handing over has to be very delicately handled. Occasionally, the patient is not satisfied with the therapist and he terminates a half-done therapy. One element of the frame is, as a guideline one can take in difficult cases which may involve suicidal attempts or which may involve need for emergency assistance or need for medicines. It is very necessary to have a psychiatrist treating the patient who is coming for therapy. So often we may have to ask the patient to first go to the psychiatrist and then come to us, or be under the care of a psychiatrist even as he comes to us. Because there might be emergencies or there might be need which can be met only by the psychiatrist. In certain cases, a hospital setup might be required because the patient may need care any time of the day, especially at night. And the patient may require admission into a hospital and proper psychiatric care in the hospital. And this requires a hospital setup. And unless the therapist is working for a hospital in a hospital setup, the therapist can't handle it as an individual. The therapist is not an emergency psychiatrist. The therapist is not a regular psychiatrist. The therapist is not a hospital setup. These are different things. And some patients may require both of them, in which case it is imperative that we send the patient to respective hospitals or respective psychiatrists and get the patient in a comfortable state. So in case the need be, he can go and get care as he requires. Emergency contact should be given to the patient that he can call up. Some people give number of a secretary, and only if the trained secretary feels it necessary, she calls up the psychiatrist or the therapist. Whereas some therapists and psychiatrists give number directly to the patient so that they can call them up wherever necessary. Other way, the therapist and the psychiatrist also have emergency numbers whom they can call up if the patient is serious or if the patient is going to do something that can harm himself or harm others. Second important element of the frame is the session. Let us go slightly in details of the session. There is something called a fixed length session. The length of the session is fixed. Usually it is 45 minutes or 1 hour. Freudian school, Kleinian school, Bionian school, Kohutian school usually use 45 minutes or 1 hour. Jungian school also uses usually 1 hour. 1 hour. In ISTDP, they use longer sessions, 1.5 hours, 2 hours, 3 hours, even 4 hours. In some exceptional cases, there may be a need to have some long sessions in between. For example, if one has had 25 sessions of 1 hour each and then one feels a need that one should have a couple of sessions of 2 hours, we can have those things in between, pre-scheduled, pre-announced, with clear discussion of why they are necessary. So this is an element where different length sessions but fixed. So you go on with a 1 hour session for 25 sessions, then have 2 sessions of 2 hours and then again come back to 1 hour sessions. Some people occasionally use this. Those who believe in fixed length session as a constant element, the classical Freudian, Kleinian, Bionian line, they find this almost like a blasphemy, but some people do use occasional long sessions. But they are fixed. Fixed, pre-announced and discussed. And then you have variable length session, which is used only by the Lacanian school, where initially you have fixed length sessions, but after some time you have variable length session, where there is no guarantee whether the session is going to last 1 hour, 2 hours, or 10 minutes or 15 minutes. At whatever point the therapist feels, he ends the session. And this Lacan used to call as the variable length session. and this act of cutting it is called tension. And what happens here is termination is used as an act of interpretation. The termination of a variable length session, the practice of tension as Lacan calls it, is not arbitrary. The variable session is put to an end, terminated, and that terminated is very meaningful. When somebody is saying something very important, or somebody is going off into resistance, or somebody is just keeping silence, at a very pregnant moment, the session is terminated. So termination there is an act of interpretation. It's a deep act of interpretation, a very profound act of interpretation. Sessions per week also varies from school to school. In Freudian school, it is preferred to have 5 days a week. Least is 3 days. Anything less than 3 weeks, 3 per week, is no psychoanalysis at all. Same for the Kleinian school, Bionian school, Cohesian school, by and large the same. In the Jungian school, it is less. It is 2 per week usually. Some even do 1 per week. In rare cases, they go for 3 per week. In ISTDP, usually it is 1 per week. I usually prefer 2 per week. And if not possible financially, then 1 per week. Number of sessions per week in most schools are constant. Like if you have 3 per week, you have 3 per every week. You don't change week by week. But so in Freudian, in the classical psychoanalytic group, the Freud, Klein, Bion group, the number of sessions per week usually are constant for a long period of time. Usually constant across the whole therapy. In certain schools, you can have tapering of sessions. In the Jungian school and ISTDP, both use tapering of sessions. So when more are needed, initially you have more. As the person becomes more healthy, you go on to more of maintenance sessions. And there is a tapering of sessions, and therefore sessions per week usually get tapered off. The beginning and the end of the session has to be sacrosanct in terms of time. Even if the person comes late, the session ends at the time it is supposed to end. Person loses whatever time he has come late. Even if the person comes early, you still begin the session only on the announced time. The start of the session and the end of the session are sacrosanct. If person comes early, he waits in the waiting room. If the person comes late, he loses that time of the session. But if the person comes 15 minutes late, we don't extend the session by 15 minutes. The session ends where it has to end. So begins on time, ends on time. It's a very important part of the frame. Another important element of the frame is the anonymity of the therapist. The therapist should be anonymous, not known to the person, the patient. He should ideally be a blank screen, a white blank screen, on which the person transfers all his projections. It is not possible, as we discussed, to be a complete blank screen, because your social media profile, your books, your writings, your video, your training, give yourself away. You give yourself away. Your therapy communication, the way you do, also talks about your language, and that gives an idea about your educational background, your social background. So we always speak with our entire past. The point is, does the other person have the ability to read it? There is no way we can detach ourselves from our past. So we always give ourselves away every moment of the day. So you always give yourself away as a therapist because of the therapy communication you do, your social media activity, your books, writings, training and workshops. And most profusely in the way you do therapy and the therapy communication, the way you respond in therapy. So you give yourself away, but we have to keep it to the minimum. We cannot make it an absolute zero. So there cannot be a perfect anonymity. There cannot be a perfect white blank screen. But we have to make it as near to ideal as possible. Can you do self-revelation? How human can you be in therapy? How human can you be in therapy? How much self-revelation you can do in therapy? All of it depends upon how pure resistance you want in therapy. And what are you going to do with that pure resistance, pure transference? If you are going to work with transference and you feel the pure the transference, the better you can work with, then you have to maintain anonymity as tightly as you can. But if you are not going to predominantly work in transference, or you don't need very pure transference, then you can take liberty with some self-revelation. In certain cases, self-revelation can be very helpful to the patient. There's nothing like this. There are no absolutes in psychoanalysis. Everything is contextual. So self-revelation is not a sin. It is a good sign. Anonymity is a virtue, but self-revelation is not always a sin. There are moments where self-revelation helps the patient, helps the therapy, helps the process of therapy, helps the process of healing. So there are no absolutes, but as a general guideline, one should maintain reasonable anonymity as far as one can. In existential therapy, not psychoanalytic psychotherapy, but in existential humanistic therapy, the therapist does a lot of self-revelation. In Jungian therapy also, therapists do a lot of self-revelation. Jung himself used to do a lot of self-revelation. But as a general practice, self-revelation has to be minimized, anonymity has to be maximized. We should be like a white blank screen, except for certain exceptional situations where self-revelation is needed by the patient. You do it and it helps the patient. It helps therapy, it helps the process of healing. With this, we end the first session of technique. We'll continue with this series of sessions and we will have more sessions on technique. I believe we will need between 5 to 10 sessions of technique to cover various points in technique. Questions, if you have, write to me at hvindia@gmail.com. I'm planning to launch a program in dream analysis. If you are interested, it will be an online program. If you're interested, write to me at hvindia@gmail.com. Thank you.